necessary to introduce Salman. Everybody knows him. He is the chairing the spine committee, and also he is the chairman of World Spinal Column Society currently. He will tell us the subaxial cervical spine trauma classification and management.
Yes. Thank you, Mehmet. Thank you, Ipe. Thank you, John. I think it's brilliant to be here, and it's wonderful that we could gather everybody together for this wonderful seminar. The big question is, can we make an impact? And it's been shown again and again that 3 to 25% of cases of permanent neurological impairment after spinal trauma are due to injudicious manipulation by paramedical personnel, examining physicians and radiology technicians. There are a few tips and tricks that we all should know. Everybody should be using ASIA, and there is a reason for that, because it's uniform, and then we can, even if you're on the other side of the phone, it's much easier to know what exactly is happening, and it's all been tested and tried. It's important that you know that what are your key muscles, and in upper limb and lower limb, what kind of sensory examination you're going to have, and every patient should have this form filled when they arrive in, and it should be repeated again and again every 2 hours, unless if you're sure that the neurology is not going to change from then on. What is ASIA impairment scale? Everybody knows it, but I'm just, for the sake of the students, I'm going to just point out that complete, when you have got no motor sensory function. Incomplete is when motor function is not preserved below the neurological level and includes sacral segment S4 to S5. Incomplete is when you have got at least more than half of key muscles below the neurological level, having a muscle grade less than 3. And incomplete is when you've got at least half of the key muscles below the level, having a muscle grade of 3 or more. And E is normal. Why is all this very important? We'll just go through our next slide and we'll find out. There is a thing called spinal shock, and you don't want to be labeling a patient as a complete injury before you have ruled out spinal shock. And this is important to look at the bulbocavernous reflex. You tag on the Foley's catheter, or squeeze the glans or the clit, or you can do electrophysiology to find out if the reflex is positive. If it's positive, then it implies that there's lack of suppressed spinal input to the sacral outflow, and that it means that it's complete spinal cord injury. If it's negative, then it's absent in spinal shock. Recovery below zone of injury. Why do we worry about we should be doing things as soon as possible? Because if you have got complete versus incomplete, what kind of neurological improvement after admission? So we know if you are ASIA A, which means you have nothing, there is a 3% chance of having a reasonable functional recovery if you are managed aggressively and you are hydrated well and everything is done according to the guidelines. If your ASIA goes to B, then 44% of patients are going to go in that grade. So we can know that nearly half the patients are improving, and 1/4 will go to good functional recovery, D and E. 5% of these patients may worsen with your surgery or your intervention. More than half of C are going to go to D and E, and 97% of patients with D obviously are going to improve further. Spine committee, as Mehmet just said, have made these guidelines with the help of looking at literature search over last 10 years. And what we found was that subaxial injury classification, which is classification describing according to the morphology, in which you have compression, burst, distraction, and translation or rotation. And then you get points accordingly for that. So if you, for example, if you have a burst fracture, you get 2 points, distraction gets 3, rotation, translation gets 4. Discal ligamentous complex involvement, if it's for sure, then you get 2. If it's intermediate, you're not sure, then you get 1. And if it's intact, you get 0. And according to the neurology, intact, root injury, complete injury, incomplete injury. And if there's a continuous cord compression, you get an extra 1 point for that. Subaxial spinal injury. So this study was published way back in 2013. And there's level 1 evidence that subaxial spinal injury classification and severity scale is recommended as a classification system for spinal cord injury. This system includes morphological, ligamentous, and neurological information in its scoring. So you've got all the features that are all included. And if you look at the rate of reliability according to different classifications, then you can see that according to the morphology, discal ligamentous complex, and neurological status, the scoring is pretty good compared to others where the scoring is pretty reasonable. So Eslick's severity scale abandons traditional characteristic of mechanism of injury and anatomy in favor of injury morphology and neurology. And so there is level 1 evidence suggesting that it's reliable overall, and internal consistency is indicated by worsening of score reflecting worse neurology. Eslick's provides good to intermediate, excellent inter-rater reliability, and it may be best applied in educational setting to confirm the fracture morphology and presence or absence of ligamentous injury between surgeons and radiologists. So study done by Vaccaro again in 2014. They looked at literature review, and they again found same inter-observer and intra-observer agreement among surgeons of all levels. So this demonstrates Eslick's was safe and effective. Sorry, can somebody unmute, mute Omar? Thank you. And you can see the same thing again and again. It's been proven again and again that we are, according to different discal ligamentous complex, neurology, and morphology, pretty fair agreement and moderate to substantial agreement when it comes to intra-rater abnormality. What about the AO spine classification? What about its validity and reliability? So I think if you look at it, AO, it has, each region is classified according to hierarchical system with increasing level of injury or instability, and represents the morphology, neurology, and clinical modifiers. And they came up with this in 2016, initially in 2013, and then modified in 2016. If you look at morphology, type A are compression injuries, type B, failure of posterior anterior tension bands, type C is failure of all elements leading to dislocation or displacement. Type F, which is for facets, as Mehmet pointed out earlier, injuries are classified by their levels, and they're either C, B, or A in this order. So let's go through each one of them briefly. If you go type A, there are 5 subtypes. A0, no bony nor minor injury, such as isolated laminar spinous process fracture. AO is also used for presence with central cord syndrome without any fractures. With A1, compression fractures include a single endpoint without involvement of the posterior wall. With A2, coronal split. With A3, it's a single end plate. With A4, it's burst. So we look at it now separately. So with A0, when you've got isolated fractures like this spinous process and there's no significant injury. A1 is wedge compression, and A2 is split. A3 is when you've got displaced transverse fracture below the joint, and you've got complete burst, which was A4. So it's easy to look up and rate. What about tension bands? So if you look at this, if there's posterior tension band involvement, there's primary physical separation through fractured bony elements, and B2 was fracture tension band posterior again, but complete disruption. And B3 is anterior tension band physical disruption. So we look at it again. So B1 is you've got posterior tension band without any disruption. B2, we have got the transalar fracture, does not involve foramen or spinal canal. With transforaminal fracture involving foramina, but not spinal canal. So anterior elements are involved here. So posterior, and then anterior with avulsion. So that is B. And we look at C, translation injury in any axis. You've got any associated injury, A or B. It should be specified separately as subtype injuries where anterior and posterior both elements are distracted without classifying as translational injuries. So for example, if you have complete disruption like that, or complete axis displacement or translation, then we call this C. What about facet? Mehmet showed that earlier. So facet is non-displayed facet fracture, F1. F2 is facet fracture without potential of instability. F2 is floating. F3 is floating fracture. This is the one that Mehmet talked about earlier. And F4 is very simple. You've got subluxation, pursed, or dislocated facet. What about bilateral injuries? So if you've got bilateral injuries, then you include that into a separate as a BL. So how do we classify this? So we start and look at if there is displacement or dislocation. If displacement, yes, you go to translation. Dislocation, if there is none, then you go on to tension band injuries. If it's yes, if it's anterior, then you know that it's B3 hyperextension injury. We talked about this. And if it's posterior, it's complete or incomplete. So then you can label accordingly. If there is no tension band injury, then you go into vertebral body fracture. If it's a burst and complete burst, incomplete burst, split, etc. So that's how we rate this. And if it's a vertebral process fracture, then it can be A0, insignificant injury. And if there's no fracture, then obviously there is no injury. That's how you classify AO classification. And then AO came up with grading of neurological deficits. They include N0, N1, N2, N3, and N4, just like the SLICs. They include neurology in it as well, and NX when you cannot examine the patient because of whatever reason, intoxication, head injury, multiple trauma, if they're intubated. So this is, again, the brief summary of neurology, N0, N1, N2, N3, N4, and NX. And you can add a plus for continued spinal cord injury. Then they included case-specific modifiers, which are rarely used, but it's important to know. M1 is posterior capsular ligamentous complex injury without disruption. M2, critical disc herniation. M3, you have got a metabolic disease of some kind. And M4, signs of vertebral artery injury. So this was again assessed in multiple studies, but yet randomized controlled trials are yet to come out. AO spine classification demonstrated good statistical agreement for group A, B, and C classification. Obviously, this was a single center retrospective study, and they needed more studies to come out with it. So retrospective analysis, again, showing the same thing, that yes, there is some reliability, but there are issues associated with, since it's a complex classification. So again, we look at, if you look at A, B, and C, so we found that the accuracy was better with A and C, whereas with B and F, the accuracy was not as good. So again, a spine subaxial classification system, inter-observer and intra-observer reliability is substantial, but there was low number or disagreement in some of these injuries. Again, another study, and they showed the same thing, but exactly showed that there were lowest values for F1, F4, B2, and A3. So these are type of the injuries that there was less consensus, and there was highest consensus for simple injuries, as you'd expect. So WFNS consensus, subaxial cervical spine injury classification we said that SLICs is easy for surgeons and residents to reproduce at this time with relatively better inter-observer reliability. There was 100% consensus there. And we suggested the SLICs should be used as standard of care to guide further treatment and given preference over other present classification. For injuries and SLICs of score more than 3, non-surgical treatment with rigid collar for 6 to 12 weeks is recommended. There's good agreement rate in SLIC score of morphology, neurology, discal ligamentous complex, and treatment chosen is more than 90% in agreement. We do need randomized controlled trials and prospective studies to validate these and newer classification. What about AO? For AO, the reliability of injuries type A, B, and C was good. Intra-observer reliability, including subtypes, was substantial. But there's lowest value for F1, F4, B2, and A3, and that needs to be improved and somehow. And highest value was for the simple types of classification. AO supplemental classification is promising with neurology and other modifiers, although it is not user-friendly and complicated. This was not quoted in our guidelines. Oops, I'm back to where I was. Okay, thank you very much.
Thank you, Salman. Very nice overview. Actually, SLICs is easier to use, but AO classification is somewhat better than SLICs. Am I right?
You're correct, Mehmet. Let me just, sorry. You are very right. I think overall, if we see, the reliability is very good with SLICs, but the problem is that those simple modifiers are not there. The fractures are not given in detail. There is more stress on neurology and discal ligamentous complex than stress on the different mechanism of injuries and the fracture type. That was the case with the initial classifications, and that has changed over time. And we've seen that I think the AO are working on, again, trying to improve this further, and I think it will happen. And we should be able to have more inter-rater and intra-rater reliability. There are many software now which can calculate all this for you as well, and so that may make it easier. But it would be difficult for countries where they don't have access to these software, etc.